What we're going to do now is we're going to move on to case studies. If y'all could pull up the case study slides. So we got two Sarahs. Okay, I'm a very concrete thinker. Okay, all right. So what we're going to talk about here is optimal nutrition recommendation for a patient treated with a highly effective anti-obesity medication from the Obesity Medicine Association perspective. The definition of a highly effective anti-obesity medication is a anti-obesity medication wherein you have a reduction of 15% of body weight or more in a clinically meaningful group of patients. So you could say, based upon that definition, that some of the other agents, it isn't just GLP-1 receptor agonists, you could say the combination topiramate, phentermine, in some patients can achieve that as well. So we're not here, to sell any particular drug, okay? We're just trying to recognize the obvious that we've entered into a new age of efficacy with the therapeutic options we have available. Okay, so this person, the Sarah 1, 65-year-old female, has the obesity, diabetes, sleep apnea, immobility. Attempted many diets, so you've heard that from the other presentations, how many times folks get engaged in dietary efforts over the year without success. Unable to walk more than 3,000 steps per day due to fatigue, shortness of breath, osteoarthritis. And she is prescribed semaglutide, titrating up to 2.4 milligrams per day. So the questions I would have with you, and Angela, I'll start with you. But one of the things that I think you've heard from Angela and certainly from Linda is that if you're going to engage in weight reduction with nutritional intervention and physical activity alone, then yes, obviously, there has to be a diminished caloric balance, and we get that. But with these new agents, what I saw from Linda's slide specifically is we're entering into an age where I think clinicians need to be aware of this, that the objective, once somebody gets put on a GLP-1 receptor agonist, may not be focused on calories. So, Angela, what should be the focus when a patient is put on a GLP-1 receptor agonist? To what degree is it calories, or to what degree is it quality?
Well, we don't focus on calories. We focus more on that quality of nutrition. So again, I go back to my planned portions of plants and protein, right? So just, telling people don't forget to eat, right? As Linda mentioned, many of our patients say they forget to eat. They're busy during the day. They don't have an appetite. So then they just don't eat. But then they go home at night when they have time to eat and they can't make up for it because, we see this with our surgery patients as well. And so we just, encourage them. If you can't, figure out a way to pack your lunch or take some leftovers from the night before or take a pre-planned meal, have a meal replacement, right? Have a high-quality nutritional supplement of some sort so that you're not forgetting to eat, right? I teach patients to have them at their desk, have them around them so that they can just have that sort of backup, right, for those protein at least, maybe not necessarily the plants, but again, having that focus on quality versus focus on counting calories is new for a lot of our patients because a lot of patients are used to counting calories from years and years of dieting.
I would just emphasize, too, that spreading the protein through the day is better utilized than having it all at once.
Okay. Well, so hopefully that's a take-home message that, again, I think this is an emerging concept. It may not be emerging for the dietitians here. It sounds like maybe you folks have been doing this for some time. But I think for a lot of clinicians, I think there is this sense of this relentless need to promote diminished calories all the time. With the highly effective anti-obesity medications that we have now available, no one is suggesting to say calories don't matter. Hopefully nobody's suggesting that, okay? And the whatever prescriptive nutritional intervention is made, not necessarily meant to counteract the success that's been achieved with these agents. But I think it's just what Angela just said here. The focus is not just the quantity of the calories. The focus now is on the quality of the nutritional intake.
Right.
Quantity versus quality. Okay? All right. So here is a patient who has vitamin D deficiency. So Sarah 2, a 65-year-old female with obesity, started on semaglutide 2.4 milligram per day a year and a half ago. She's lost 25 pounds. with a current BMI of 26 kilogram per meter squared. DEXA scan, revealing a percent body fat of 40%. Okay, so still rather high on the percent body fat. Lean body mass, 85 pounds. For the that's pretty low lean body mass. Bone mineral density is mildly in the osteoporotic range. Vitamin D levels low. Strength assistance with walking, rising from a chair, climbing chairs, and falls, and these types of things. Questionnaire. This questionnaire was 7, which does suggest possible sarcopenia. 6-minute walk test was 300 meters, normal being 400 to 700 meters. And so if you look at all of these assessments, there does seem to be a suggestion of the sarcopenia. So you have reduction in body weight, but you still have a high percent body fat, and now you have evidence of sarcopenia. So Linda, I'll start with you. From a nutritional standpoint, because that's what we're here to talk about, from a nutritional standpoint and maybe behavioral standpoint, what are your recommendations in this particular patient?
My first recommendation would be to look at her caloric intake and work to stabilize that to stop the weight loss, but then focus on what she's taking in, not just the protein, but look at her vitamin D intake there, and assess the physical activities. She has limited physical activity, but to work on more weight-bearing activity.
So you still have a person who has a high percent body
Body
fat,
fat.
right? And so now you're like, okay, should they be continuing to have weight reduction?
No.
Or what?
Yeah.
Or, you know, what's the plan? What's
Well,
the plan?
I think these are the hardest people to treat, actually. And sometimes these people come in even to clinic, with higher weights even, right? So they do need to lose some weight, but what they really need to do is lose fat and gain muscle.
The muscle tissue. Right. And as you said, it's very difficult to gain muscle tissue, so we want to at least protect the muscle tissue that she has through diet and physical activity. I would, yes, if she can lose more body fat, great, but right now it's a matter of protecting bone and muscle that she has.
And so if we could go back into time, wouldn't it have been great if this patient had been seen by a clinician that was here at this program, or had sought the counsel of dietitians that are here at this program, and had said, okay, before we implement the therapy with one of these highly effective anti-obesity medications, why don't we preemptively concern ourselves with avoiding this sort of situation? So, Angela, yet again, can you tell the folks about the 5 Ps and such? You're prescribing this GLP-1 receptor agonist. What are the practical things that clinicians can do to help avoid this exact situation?
Well, we do body composition, as you mentioned, Harold, that you do from a research perspective, so you have that available for patients clinically too. We really focus on that, and I know there's lots of discussions around, which body composition, what type. I think you do what you can in the office, right? We have a bioimpedance analyzer, and it certainly helps patients to understand this situation, right? That they need to really focus on preserving that muscle mass. And so we may go slower a little bit with the titration of the medication, as Linda mentioned in her talk. We may pick a different therapy, actually, that maybe doesn't promote quite as rapid of weight loss or quite as rapid of appetite suppression. Because as Linda mentioned, and as I think, a lot of you know in the room, if you're going to gain muscle, you need protein, but you also need calories. So there's that fine balance between I'm appetite reduced, but I need to eat enough calories that I can, when I'm in the gym, that I can actually gain some muscle mass. So that is very, very, challenging, right, to accomplish that at a level that we're trying to do. So I think, really focusing on teaching these patients that that's what they need to do. Even if it's hard to do, when they can understand that, I think they take a little different approach than just, I'm going to take a medication, I'm just not going to eat. And that is what sort of a lot of times I think can be the default at baseline without this education or without this understanding that you have sarcopenia, and we're worried about that for your longevity and your health long term.
And I think that's where measurements of body composition can be valuable, regardless of the method used. If you're using consistent measurements serially to be able to work with the patient to explain changes and ideally progress. I'll also throw in that carbohydrate, as part of those calories, is needed for the energy to be able to perform the activities as well.
Yeah, so there's another message. What we may be finding here in the next maybe year, 5 years, or whatever, there may be a more definitive diagnosis of the obesity rather than being solely based upon body mass index. I think you're going to find more and more of a gravitation towards defining obesity more on the basis of body composition as opposed to body mass index alone. I understand we do have some people here, experts in physical activity and such. One of the things, and I think this goes to what Angela was saying, is that in educating people exactly what is resistance training. So one of the patients that I mentioned that were able to maintain their muscle mass on DEXA with substantial weight reduction was a biker. And if you look at the list of literature I've seen, usually biking really doesn't do a lot as far as resistance and muscle building and everything. So we asked them, we say, how are you able to maintain this muscle mass? And they said, by biking. We said, biking, the literature says that shouldn't work. And then they threw in the qualifier and they said it's mountain biking, which apparently is very different than just cycling downhill all day long. So again, I think educating our patients on exactly what is resistance training and how do even similar sounding exercise activities that they can have profound differences depending upon how these are conducted. Yes, ma'am.
My question is, well, let me just preface. I know that as a nurse and as a student, we don't have a lot of focus on disease prevention compared to disease management. Not a lot of focus on well-being in the hospital. So I was wondering, just how far do you think that we should go to promote nutritional wellness? For example, increased protein has been a pop culture thing recently, and that has significantly increased the intake of protein in our adolescent population, especially as they're exposed to that media. And our older adult population has different intentions, oftentimes related to disease management and lifestyle and being able to have that healthy lifestyle. Do you think that we could do this similar promotion that we see externally where everybody can see your weight and we have those calories and they're constantly being externally validated by our media and protein now? Do you think that we could do that with micronutrients, or do you think that's taking away from the point? Because we do have a lot of external benefits from micronutrients. We can, teach about hair and skin, etc.
Okay, well, thank you. I'm going to kind of paraphrase this. So, Angela, I'm going to start with you. She said, this is just stunning to me. She said, at least in nursing, sometimes they didn't get the nutritional education they did during thank goodness that doesn't apply to doctors, right? Doctors get tons of. What is the massive training that physicians get during training as far as nutrition?
Like an hour, maybe. How many calories per gram of protein and carbohydrate, and But I think your point is well taken. That I tell patients all the time, our current standard American diet, which the acronym is SAD, right?
And what's the acronym stand for?
Standard American diet,
okay.
But SAD, it's sad. So we kind of joke about
I
that.
see.
That
I
our
got
standard
you.
American diet, the acronym is
It's sad
SAD.
and it's sad. Yeah, okay, I got
But
it. Yeah.
because, it doesn't promote health and well-being by nature, right? I mean, just living naturally in the world around you today with increased stress, increased, Instagram and all the staying up late at night and having a sedentary job, this doesn't promote, by nature, health and well-being, right? So we have to teach people, all people, that this is something you have to figure out how you're going to manage the world around you. So we never had to, animals live in their environment, and they live into their environment. I mean, that's what they do. I mean, they live in their environment by nature, right? And to ask somebody to live opposite their environment is not natural. And so we're asking people to do things that are not natural. But we have to try to encourage them at least to find ways of managing the environment around them and finding ways to sort of, get the micronutrients they need at the same time that they're getting the proper nutrition that they need. And there's sort of various ways to do that, I think, is the point.
And so to her second part of her question, we have labels, which I'm personally in favor of. And they do have things like the amount of calories per serving and such, which I think if you're trying to get away from what you talked about before, which is, energy-dense foods, that's really helpful to make proper choices and such. But they're also, in the food labels and such, they do have micronutrients and such. And I think people have a somewhat understanding of the calories. I don't know they have any understanding about micronutrients or amount of protein. I mean, to what degree, when you're educating patients, do you talk about the various aspects of food labeling?
I think it's a big part of what many dietitians will talk about in choosing food. However, we don't need to make things harder than they already are. And as Dr. Fitch is saying, our lifestyle is complex, it's the whole lifestyle. So if I'm working with the patient with sarcopenia and I'm concerned about her protein and calcium intake and vitamin D, I'm going to probably pull that out on a label, although she's going to be getting some supplements.
Patient-centered is what you're saying, right?
Patient-centered.
Yeah.
I'm going to focus on that. But to go through all of the, even macronutrients, but the micronutrients is way too complex for most people. So I think that's where I go back to emphasizing, well, what are the food categories we're eating? Are you having a variety of categories? And then ideally variety within the category. So it's not only carrots, ideally. At some point we'll get a little broccoli or a potato or something else. But that, if we can have that variety of categories and variety within the categories, the odds are most of us are going to get the micronutrients we need, and then patient-centered with specific needs and nutrient needs.
Yeah, and what I'm hearing from you is you're talking about medical nutrition therapy. You're talking about food as medicine, right? You're saying
yes.
You have this specific set of needs as a person in an environment,
right,
like Angela said, and you have these specific, we're going to focus on what you need with regard to the macro and micronutrients in a specific food, right?
Yeah.
Yeah, okay. Yes, sir.
Dr. Bates, you mentioned heart. The SELECT trial, all to the positive, the heart failure trials are great. What do you see on DEXA when you look at heart muscle? Do you see any your comment earlier on, you just dropped it.
Yeah, I guess because I'm curious about it. And so the question is, what about, imaging and functionality of the heart on these medications? And that has been something that, because again, when you look at the reduction in lean body mass, I mean, it's, heart's part of that. There's other body organs as well that are part of that. Now, one way you could look at that, you could say, well, if you have a fatty heart, maybe reducing that fat, it's going to reduce the mass in the heart, and maybe that's a good thing. And that would be supportive of studies that have shown favorable effects with GLP-1 receptor agonists in patients with heart failure with preserved ejection fraction. Not necessarily with reduced ejection fraction, but with preserved ejection fraction. DEXA really doesn't assess the heart, but there are certainly studies that we do with MRI and those types of things, looking into that. And I don't have a really good answer for that. I think, as I mentioned, I think that there's much more that needs to be learned about the functionality of the heart in patients given GLP-1 receptor agonists who do not have heart failure. Okay, that would be an interest of mine. Yes, ma'am.
Good morning. I teach nutrition classes to pre-med and pre-health professional students, and we actually just started a nutrition major so that those students can get a major with rigor and then go on to their graduate programs. But you mentioned the word adjusted body weight, and I don't think many people use that or familiar with that. So I'm curious your approach to calculating the ideal body weight, that's the basis for that, and then what ratio you use to multiply.
I just use ideal body weight because I'm like, it just sort of gives a number to go by that is different. In fact, we tend to use, from a protein requirement standpoint, we tend to use in our clinic more of how much lean body mass they have, how much skeletal muscle mass they have, and try to optimize the protein based on that. But I think for most people, again, just focusing on getting again, I go back to, because people come in, I'm so confused, I got this TikTok, I got this, and I just say planned portions of plants and protein. Like if you're eating a plant and a protein for breakfast, and a plant and a protein for lunch, and a plant and a protein for dinner, and another one for a snack, you're going to be doing pretty good with your nutrition. I think versus, calculating or trying to do all these things, I think, just really focusing on making sure that they're doing that throughout the day and not skipping meals is really critical. I don't know that most of our patients, actually track it as much as they do it mentally by saying, oh, Dr. Fitch told me I need to, make sure I'm not skipping meals and I'm eating some protein. So I'm going to, grab this protein bar or protein shake or something because I don't have time to eat, right? And so educating them that that's okay, I think is what, or just even educating them about that, right? I've always been amazed in my training that, like I said, from the difference between how we treat athletes, between how we treat normal people, right, or people with obesity in particular, is just fascinating to me because, you would see people, athletes running around with their shaker bottles and, drinking their protein shake while they're working out. And again, I think, helping patients understand that that's kind of okay for the rest of us to do too. If, would I rather that they have what I rather in the morning instead of my protein shake, have an omelet with some chilies and some, I don't know, what else are we going to put in there? Some mushrooms, for micronutrients. Yeah, of course, I'd rather have that, right? But do I have time to make that in the morning? Maybe on Saturday, but maybe not on, Monday and Tuesday and Wednesday. So I think, helping patients just understand that this is a process is what's key. And not so much get stuck on a number, I guess is my point, relative to that. But I think the point is that most people need probably a little bit more than what they're getting, especially if they're taking a medication, right? Not just as a whole in the population, because we have data to show that people are quote unquote eating enough protein in the United States. But at the same time, I think it also depends on the quality of that protein and all sorts of other things. So.
Yeah, even with the SAD, this typical American diet, we're getting more protein than we need because we tend to be a very meat-focused, animal protein-focused society. So most people are getting more than the 0.8 grams, for their weight for protein. When they're on the medications and the need goes up to that 1 to 1.5 grams, it's a little tougher, particularly with the decreased appetite. And I think that's where we go back to saying, you call it planned portions, I'm saying structured meal plan, but divide it through the day. And can you aim for even 20, 30 grams 3 times a day would pretty much meet the needs. Now, I find that a little tougher in the morning, unless you're using a shake or something, but you can do that. And that boils it down to practical to-do behaviors. And that's my approach. Here's what's to do, not to do. Not do.
Yeah.
So to be not there. Yeah.
Just curious, Dr. Fitch, Linda, so we know in bariatrics, for example, we've emphasized multidisciplinary care for a long time. We know the value and role of the registered dietitian and the support registered dietitians can bring to that. We don't have guidelines yet, per se, for GLP-1 use and support, but I wonder if with upcoming guidelines, will we see more emphasis on the importance of the registered dietitian as part of the team and supporting these patients?
I hope so. I think it's hard to access is one of the issues, especially around the fact that a lot of people don't take insurance and people want to access this through their insurance, and then a lot of insurance doesn't cover it on top of that. So I think, we're going to have to find some ways to deliver this care. I'm hopeful we can do it in some sort of bundled payment fashion so that we can do it in a comprehensive way without sacrificing, patients. And I also think that a lot of patients don't need to see the dietitian like every month or every week, right? I mean, some patients need some intensive support, and other patients don't need as much of intensive support. So I think there'll be ways in technology, as I mentioned, that can help all of us to do better on a daily basis, right? If I'm taking pictures of my food and I notice, hey, I'm only getting 50 grams of protein a day because I'm skipping lunch, I have enough education to be able to fix that kind of myself, right? But again, is that going to be everybody? So I think, I've always had like this 30-30-30 rule, sort of thing, like that 30% of people are probably going to need intensive sort of intervention, 30% of people more sort of light intervention, and 30% of people are probably going to be able to kind of manage it themselves because they have enough education and wherewithal to do that. But again, I think that's what we're going to try to figure out in the long run.
Yeah, that's where we go back to that patient-centered care. Assessing what does the patient need, and everybody doesn't need the same blanket approach to it. You're right that it will take time for this to evolve, I think very similar to what we've seen in bariatric care involving the interdisciplinary team. And those guidelines will come when we get the research. In the meantime, we have best practices, so I will just alert you very soon. There's been an article accepted for publication in the Journal of the American Dietetics Academy of Nutrition and Dietetics on the evolving practices and best practices for registered dietitians with obesity medications.
Thank you.
Just a comment. We verified insurance coverage for medical physiotherapy for obesity before the patient even asked to see me. It's about to be surveyed the disease. And we had many patients, 2,000 patients and more a year. And we found coverage for 99% of cases.
So the comment.
Maybe we actually don't need to.
I think it's actually very regional. The comment was around coverage for medical nutrition therapy for obesity as the only diagnosis. We know that we have some coverage for diabetes and chronic kidney disease. Yeah. So if we can identify those patients that have those overlying comorbidities, it affords them the ability to see the dietitian. I think the obesity coverage is very regional. So it depends on where you're at in the country and what plan you have. We have very good coverage as well for probably 90% of our patients in Massachusetts.
The patient verified, it doesn't take a long time, but
yeah.
And maybe offer out-of-pocket costs.
Yeah.
Based on Medicare,
Yep, that's what we do. We offer out-of-pocket costs. We also offer for patients, you can use chronic care management codes. You can use a lot of other coding to sometimes have a patient be able to, see a dietitian, using some of this other coding. So just depends on how you're set up.
So again, want to thank you here. My takeaways would be patient-centered really does mean patient-centered. Hopefully you heard, diversity of approaches for our diverse patients that we see, depending upon, as Angela said, their environment and such. Really want to emphasize the importance of hydration. Really want to emphasize that there are other options for patients rather than foods and such. There's meal plans that that Angela talked about and such. And then finally, this whole issue about what is the role of nutrition in patients on highly effective anti-obesity medication, and I think a emerging message is that the focus is on the quality of the dietary intake and maybe not so much the caloric restrictions and such. And with that, I want to thank the folks for having us here, and thank you all for coming. Thank you.
Good job.